we'll talk more about that. But we are at 4:45, so we're going to get off. And Elias, you're in Baltimore, right? Is that where you are right now?
Yes, that is correct.
Right.
First year in front of the.
Okay. Yeah, no, I know that, but I was just wondering if you were in town.
Yes,
okay, well, we'll get off. We'll let you proceed. We'll keep the audio on for any questions, but let's go ahead and get started. Unless Kathy or Doris, do you guys have any updates or introductory comments?
Hi everybody, it's Kathy. Let me put my.
We
can't hear you.
Yeah, we can't hear you.
Are you able to hear me?
That's better. Yeah.
Okay. All right. Great. So, hi everyone. I just wanted to let you know. Firstly, hi Elias. It's been a while since I've seen you. But I just wanted to tell you we just finished the National Medical Advisory Committee, and we spent a good bit of time talking about this particular these difficult case calls. And I have to tell you that the committee was really impressed with everything that's gone on, and grateful for the hard work on everyone's part, particularly Ellie and Teresa, and also the work of all the fellows. So I just wanted to share that this is not being lost on the organization or on our volunteers on our National Medical Advisory Committee. They're very excited and very happy that this is really come so far in such a short period of time. So I'm going to step off, and I just wanted to let everyone know that. So thank you.
Thank you. Thank you.
Well, thank you.
Okay.
Okay, so I guess I'll get started then. So I'm going to be presenting a case that I met on our inpatient service last year, actually, so in 2017, where we were consulted in order to provide aid with management and diagnosis of this patient. This was a 50-year-old African-American left-handed woman who came in with 1 month of worsening lower back pain. She had a history of chronic back pain, but there was kind of a more subacute onset on top of that chronic lower back pain she had had, associated with some lower extremity pain and weakness. And additionally, she had both GI and GU symptoms, including urinary retention and incontinence and constipation. So to outline a little bit more kind of the time course of these this symptomatology that she was experiencing. So regarding the back pain first, so she had a chronic history of lower back pain, and she had notably reported that she had had an L-spine MRI the year prior due to this, but at the time it wasn't associated really with any other symptoms except for pretty typical description of a kind of musculoskeletal nature of a back pain. And her lumbar spine MRI at the time had some mild degenerative changes, but really no other abnormalities. Over the past month, however, she described that this had been worsening, and it had characteristically changed in nature. Now she described kind of a sharp and burning in nature pain, not only in the lower back, but also kind of a little bit in the perineal region as well. And notably, approximately 2 days prior to presentation, she developed some lower extremity weakness and actually became unable to ambulate. Backing up a little bit more, though, she had had some additional symptoms, including sensory symptomatology, which she described as a burning and tingling sensation in the bilateral lower extremities in the weeks preceding her presentation. As well as a week prior, she had developed urinary symptomatology, as I previously mentioned. This actually prompted her to present to the emergency room, other emergency rooms that she was unable to void, and she had required a straight cath in order to void. She was told that this was due to a urinary tract infection, started on macro, but really no further workup was performed. But then this actually progressed to her developing incontinence over the next 2 days. And so with these complaints, especially her main concern was the incontinence and the inability to ambulate for 2 days, she presented to the Johns Hopkins ED for further evaluation.
Yeah, if I might just add one comment here, Elias, and that is, a typical person with a urinary tract infection, even if they're in the moderate to severe category, pretty unusually will develop what almost would certainly be, if you had done a pre and a post void in this case, detrusor sphincter dysynergia. So one has to put your thinking cap on in terms of what would get somebody to the point where they'd have a high post void residual with a tight sphincter and a failure to void. So it can happen, but it's got to make you think something pretty dramatic is happening if this patient requires catheterization because of a UTI.
Yeah, agreed completely.
I mean, without the underlying neurological course, of course. If we know something about the underlying disease, if it's MS, it's other things, NMO, then the question becomes, okay, sure, in that context. But this is somebody coming to light for the first time, so it's got to make you pause. I'll stop there.
Yes, definitely, completely agree. And it was unfortunate that this was missed at the time, but fortunately, we got to her after 2 days, relatively quickly. She came to attention, unfortunately, due to severe deficits, however. Then, so in terms of just to provide a little bit more regarding kind of her past medical history, so just first of all, in terms of review of systems, really nothing to note otherwise except for what I mentioned on the previous slide. She did have a past medical history of diabetes type 2, non-insulin dependent, for which she was on an oral hypoglycemic, so metformin. She had hypertension. She had a history of alcohol and opiate abuse, however, had not used in over a year. Denied IV drug use. She mainly described a history of prescription opiate abuse. And additionally, she had a history of syphilis, which status post treatment in 1997. And fortunately, the Baltimore Health Department maintained very good records of this, so we were able to ascertain that she had indeed been treated back then. And I'll mention later what we had also had results from the laboratory testing back then and what the titers of the RPR was.
Yeah, and one point of practical importance is that with the history, or even without the history, somebody coming in and doing a tox screen, one would want to make sure she didn't fall off the wagon. Just one practical point, that as you go up in the dose of the opiate, you increase, of course, the anticholinergic effect, and it's not unusual for males or females to go into Druser sphincter dyssynergia in the context of high doses of opiates. So I'll just leave it at that.
And that's actually one of the reasons that she had been dismissed from the outside hospital emergency room, because she had in their chart this history of opiate abuse documented. I didn't actually see a UTOX from that emergency room visit, but because of that, there was sort of a bias against her, and it was attributed to opiate abuse, even though she adamantly denied having used in over a year. So this kind of led the physician there to dismiss her and attribute her urinary attention to that.
Yeah. Very disrespectful, I agree.
Yes, unfortunate. In terms of her...
I think someone's trying to interject with a question. You're still on mute.
Hey, Bob, I think that's Bob Lissack. It's Uncle
Yeah.
Bob. You're still on mute, Bob.
In the same area, Bob, where you selected to share your webcam, you should have a microphone icon. Is that green? Yeah.
Elias, keep going till Bob gets tuned in. He's done this 100 times. He's been on with us. He gets on, but keep going until his sound is working.
Okay. So in terms of the family history, it's really only notable for heart disease and diabetes. There was no family history of malignancy or neurologic or autoimmune conditions. And then I mentioned already this prior history of alcohol and prescription opiate abuse, and just screening for any other exposures. We weren't able to ascertain if she had had any sick contacts or any recent travel outside of the state of Maryland. By the way, this presentation occurred approximately in the month of April. This is sometimes useful when we're thinking about kind of the seasonal distribution, especially of some of infectious diseases, which are sometimes common in some of these areas, especially in the state of Maryland, including Lyme disease. So just proceeding, in terms of her neurologic exam at the time of presentation, her general exam was really unremarkable, with the exception of some pitting edema in the lower extremities, which she actually reported she had only noticed over the few days prior to presentation, although notably, again, she had not been ambulating for about 2 days prior to presentation due to the lower extremity weakness and unsteadiness that she had been experiencing. Her neurologic exam, her mental status was intact. Her motor exam was notable at the time of presentation for weakness in the lower extremities in approximately pyramidal pattern. However, there were a few things that were unusual. I mean, she did have flexors affected more than extensors in the proximal regions. However, her ankle dorsiflexion was completely intact. So she was 3 out of 5 proximal at the hip flexors, 4 at the knee flexors bilateral. But again, the exam was somewhat limited because of the significant pain that she was experiencing in the lower extremities that I described previously. Otherwise, she was full strength, however. Her reflexes were intact and did not appear to be asymmetric or abnormal, with the exception of absent ankle jerks, and her plantar responses were equivocal. Her sensory exam was notable for saddle anesthesia, and in addition to this, she had diminished pinprick in the distal lower extremities. I do want to note that she does have a history of diabetes as well, and it was unclear to us if she had had any distal sensory neuropathy diagnosed previously, and she didn't really, however, describe any symptoms there. Her main symptoms were located more proximally, including the painful paresthesias that she was experiencing. Vibratory sensation was absent at the toes, decreased at the ankles, and her proprioception was absent at the toes as well. Coordination was grossly intact, at least in the upper extremities. In the lower extremities, due to the pain and weakness, it was somewhat difficult to examine, and her gait was actually not examined, despite the fact that she was anti-gravity in her lower extremities, because mainly of the pain, however, she was not ambulating as well.
Hey, Elias, could you make a comment about just the anatomic thinking about the saddle anesthesia in this patient when it comes up, in terms of how we think about that in terms of the lamination pattern or the sensory streams in the cord?
Yes, I mean, I think that generally, like for all neurologists, I think that hearing the term saddle anesthesia really sets off bells, kind of thinking about a localization, especially in the conus, especially. With the kata, it's often the distribution of the symptoms being very symmetric and not having kind of localization to one side or the other points a little bit more to the conus rather than to the kata equina. As I mentioned previously, she was having urinary and bowel dysfunction, which can localize really to either structure. However, I think that at this point, kind of with this symptomatology that we were seeing, we were mainly concerned for either a conus or a kata equina lesion at this stage. And one of the difficulties, I think, in the clear localization in this instance is the pre-existing history of diabetes and the unclear contribution of this to some of the findings, such as the absent ankle jerks, such as the diminished pinprick in the distal lower extremities, which did not kind of obey a specific radicular distribution.
I got it. I think I've been able to call in now. Thanks, Doris.
Yeah.
Bob, listen, another point to make, one was emergency rooms don't take thorough histories, so you didn't even need to know about the TRUSA. All you needed was the history of her other complaints and know it wasn't an isolated urinary tract infection. We see this all the time. And then the other one, Leib Scheinberg always used to point out that if you have decreased reflexes or normal reflexes with upgoing or equivocal toes, think about the conus.
Yeah, that's an excellent point. Yes, I forgot to mention the equivocal toes. Yes.
No, you have it there, Elias. It's there. It's there.
I didn't mention them in the localization. Yeah, that's an thank you so much.
Yeah, and where that may come up a lot in the HIV population, and particularly those with CMV, Bob, is where you have radiculomyelitis or radiculomyelopathy, upper and lower. So it's a very important point.
Yeah.
Okay, great, Elias.
Yeah, so given this presentation, in the emergency room, she was immediately taken for a lumbar spine MRI, especially with the localization we just discussed, and this concern of, again, there's this history of opiate abuse as well, some concern for IVDU, there was concern for possible either abscess formation or and mainly infectious etiologies were what were entertained. Again, she had, I didn't mention this, but she had some perhaps low-grade fevers over the prior days, which had been attributed to the UTI, but otherwise no objective fever was documented, however, in the ED, either at the other emergency room or at ours, but she reported some kind of subjective chills. This is the sagittal MRI of the lumbar spine that was initially obtained in the emergency room, and so you can see here we have the T2, the T1 pre-contrast, and the T1 post-contrast. And so what we can see is this lesion here in the essentially extending to the conus in the spinal cord, which exhibits this interestingly nodular enhancement here. But additionally, in addition to that, there's this kind of diffuse leptomeningeal enhancement involving both the kata as well as the leptomeninges surrounding the lower lumbar spinal cord as well. And so this is better, I think, on the axials, which I have on the next slide. at 2 levels. So one is including mainly the conus here, as we can see, so the distal tip of the spinal cord. And so we can see here the nerve roots are deformed, but we can still see the centrally the conus medullaris, and we see here a area of T2 hyperintensity with associated enhancement of the T1 post contrast. And then going just lower down, we can, the spinal MRIs, the axial especially, are not of the best quality, but we do observe some areas where we can actually note nerve roots that are enhancing after contrast administration in the cauda
I guess, Elias, one of the questions would be, are those the meninges around the root that are, sheath rather than the nerve
Yes.
itself?
Is it truly?
I don't think you can tell. You can't expand the view that much.
Difficult to tell, and again, the quality wasn't ideal, though. I mean, I would argue that potentially at this site here, it does appear, at least comparing to the T1 pre.
Yeah. No, I agree. It looks enhanced.
You could imagine that perhaps that it's the entire root rather than just the the leptomeninges surrounding that region. Although again, as you said, it's difficult, especially with this MRI, to see that.
But if you look back on your sagittal, it looked almost as if there was something going all the way down to the sacral root. See it?
Yes. So this
follow it all the way down.
Yeah.
There it is.
Yeah.
As if
But if you follow it,
this wasn't really confirmed that well on the axials that I pulled up. So it was mainly in the proximal kind of nerve root rather than in the distal region that this was observed, the enhancement.
by the way, if you take a look at the end of the conus as it comes down, anatomically, go back that one slide right there, the one all the way to the right, you can see it. You usually don't get such a beautiful view of the filum terminale and what becomes later the coccygeal ligament. So this is the end of the dura, which becomes that filum terminale. And if you go all the way down, it anchors, coccygeally. So
way down.
Sometimes you wonder if you get some shortening, whether they have some pain in that region, but very rarely do you see this kind of pattern at the very end like that. So I think you have conus, you probably have some root, but you also have that filum terminale, which is that extension.
And then it appears that there's likely some abnormality. As you can see, the T2 hyperintensity kind of extends superiorly here. And so she was imaged, the entire spine was imaged as well as the brain. And the pertinent finding is here in the thoracic spinal cord, where we actually see, first of all, we can actually see superiorly as well. We see this area of hyperintensity. It's non-contiguous, but here there's actually a large segment that extends from here, mid-thoracic spinal cord, lower thoracic, all the way kind of down here. We see this area with associated enhancement in the lower thoracic cord here. We see this region posteriorly. I did not include actually the axials here, but this was mainly kind of a central predominant pattern of the T2 hyperintensity and involving the thoracic spinal cord.
Looks it. Even on the sagittal, it looks it.
I'm sorry?
Even on the sagittal, it looks pretty central.
Yes, exactly. So it looks pretty central, and the enhancement, however, was located more posterior.
Posterior.
Is in this region here. Otherwise, her cervical spine imaging was unremarkable, and her brain MRI really only showed a few scattered subcortical, non-specific white matter lesions. Again, she did have a history of hypertension and some substance abuse and diabetes as well, and so it was not entirely unexpected. So at this stage now that we have a little bit of a better idea about what's going on, I took the liberty to put in a differential diagnosis slide here. I really think that the first thing that often comes to mind when we're faced with a situation like this, I really think is infectious. As Dr. Froman mentioned previously, especially in HIV patients, CMV, lumbosacral myeloradiculitis is clearly a concern. Additionally, an immunocompetent host, HSV2 infection, can also cause a similar syndrome known as eponymous with the eponym of Ellsberg syndrome. VZV and EBV have also been described to cause this. Again, being located in the geographical region that we are, Lyme was a consideration in the context of a myeloradiculitis. There was a history of syphilis that I mentioned in this patient as well, so that was also a concern. It is, after all, the great mimicker. And again, some other infections, which, again, she didn't, tuberculosis was a consideration, mainly consideration in developing countries, but it's clearly a consideration here as well. And I mentioned the history of alcohol abuse as well. And then rare kind of infection that have been described to cause this would be like schistosomiasis, especially. But again, there was no travel to Southeast Asia for this patient or anything like that. And then in the Central and Latin America, actually a lot of the flaviviruses have been described to potentially lead to a similar presentation. In addition to infectious presentations, we had quite a bit of discussion regarding the possibility of malignancy, especially lymphoma, so an infiltrative process causing this. So that was definitely a concern. I mentioned this is an African American woman, and we see a lot of sarcoidosis in our African American population here, and so that was also a consideration on our list. And then I've listed a few other rare, well, not so much rare autoimmune conditions, but conditions that have this presentation rarely, either in MS, for example, I'm listing it there just because it's the most common disease, and atypical presentations of a common disease are more common than a rare disease. However, it would be incredibly unusual for it to present like this, and there would have to be some sort of superimposed process for that radiculitis to occur. Otherwise, CRMP5 has been described to cause a paraneoplastic myelitis, which may be associated with radicular involvement. Guillain-Barré, there are cases of Guillain-Barré presenting with myelitis concomitantly. And then
the problem is it's too slow evolution. It's past the 4 weeks by definition.
Yes, well, so the lower back pain had been going on for about 4 weeks, actually.
It's right on the edge.
Ambulatory dysfunction, urinary dysfunction was less than that, but yes, you're right. It's kind of at the edge of the duration for something.
Early
like
autonomic would be unusual. Early autonomic bladder
yes,
would be unusual. And
then just as a last, just to complete the differential, just as a last, I listed condition. Was there vascular? We see a lot of arteriovenous. I actually meant to write there dural arteriovenous fistula. I'm sorry, that was a typo there, but we see this presenting often, and we often see atypical presentations, including we've seen patients with dural AV fistulas who have had PET avid lesions with marked contrast enhancement. And so I listed always there because I always like to remind myself of the potential for this to be a non-inflammatory or infectious process or non-malignant process, even in a situation like this, because it's something to keep on the list just in case we're unable to find an answer otherwise.
Yeah, anti-HU or AAN1 can give a necrotizing myelitis, but they're usually cervical, and they're rare anyway. Elliot Mancall reported some of the first of those pathologically in the 50s.
Your list is fantastic.
Incredible.
Yeah, I would wonder about two other things to maybe put on it. Would be the anti-Mog syndrome, since that appears to affect the conus quite a bit, and this emerging syndrome, GFAP syndrome, which causes a meningoencephalomyelitis, particularly with the meningeal enhancement that you've demonstrated in this case, is intriguing for those two possibilities.
The ones that have brain symptoms, which this patient doesn't have that radial pattern that's pretty classic,
right.
Which this isn't, and this one doesn't have optic nerve. Although what's interesting is, and I raised that question at the Academy, when you have the original Mayo series, when it was their own patients, had a fair amount of papillitis. When they have the larger series, where they have a lot of cases where the antibodies, were sent in, and they can't really guarantee what the clinical picture was, that kind of wasn't as common. But they reaffirmed that the cases of their own, they have a lot of optic nerve disease, Steve, with papillitis.
With the GFAP.
Yeah, with GFAP.
Yeah, they just reported that's going to come out a series of cases, as you said, Bob, with swollen nerves, but with pretty good acuity. And the question is whether or not, because of the inflammation of the meninges, whether or not some of these cases of papillitis are actually perineuritis, which inflammation is mainly in the sheath and
Right.
it infiltrates the nerve
Yeah,
to cause a
Yeah,
little
we have
bit.
a patient with granulomatosis with angiitis, previously known as Wegener's, and for good reasons, no longer known as Wegener's. And he came in at 2800, and within 2 days he was 20/20, and it was clearly peripapillitis.
Right. So, and then that appears to be the case with the MOG syndrome. So I'm just so interested in the fact that this is, extending into the nerve roots, that, both of those processes may also have a fair amount of meningeal enhancement associated with it.
And that's the way it would have to get into the nerve roots, because MOG isn't found in the roots.
Right.
But the other syndrome is more in the, I guess in China and Japan, is the neurofascin and the contactin. They get CNS and PNS, including brain. So that, and you can actually get that done now. I think Alan Pestrunk's lab does it, among others. And they have a very nasty a combination. When they have the CNS and PNS, they get a very nasty syndrome.
Okay, I think that's a great discussion. I think we'll go ahead and move on to more of the interventions and confirming the diagnosis here, Elias.
So just starting with our basic kind of laboratory workup that was performed. So really our general labs are unremarkable. A few things that we mentioned previously. So HIV status incredibly important, especially with the concern for a CMV, myeloradiculitis. That's why we performed both an antibody and PCR test, and they were both negative. Lyme, especially within the region that we are, West Nile. I mentioned that she had a history of syphilis. So her EIA is positive, as would be expected, lifelong, but her RPR was only 1-to-1, and we were able to get from the Baltimore Health Department that her titer was 1 to 256 prior to treatment in 97.
Great work, by the way. That is great work. Wonderful. Keep going. Great work.
Not me, the Baltimore Health Department is really good at this. And so consistent with a 4-fold decrease, which is expected to occur after treatment. Additionally, she had a quantiferon gold, an extracted nuclear antigen panel, and an ANCA testing, and they were all unremarkable. In terms of her cerebrospinal fluid testing, she actually underwent serial lumbar punctures. I'm showing a representative result from the first one. She actually went serial mainly in order to assess flow cytometry and cytopathology, because as I mentioned, there was a concern of a lymphomatous process, or some sort of malignant process. She did have a pleocytosis with 56 white blood cells, and which were exclusively mononuclear, 79% lymphocytes, 21% monocytes, an elevated protein at 111. The glucose was not decreased. Again, there was a corresponding serum sample of 95, and it was 65. Repeated samples for flow were unremarkable, or there was no clonal population. IgG index was 0.7, and there was only a single CSF-specific oligoclonal band. All the viral PCRs that were sent off of the CSF were negative, and West Nile IgM additionally was negative as well, and all the cultures were no growth.
Additionally, can I ask you a question about the CSF? So a lot of places are now reporting the net number of bands that are CSF specific, which can be misleading. So if you have 5 or 6 bands in the serum, and you, let's say, had 1 extra in the CSF, that's important to know the raw numbers, and that's the way the Mayo reports them, at least to us. And the reason that's important is multiple bands in the serum is an autoimmune systemic reaction or inflammatory. It's not just, so the net number is by itself sometimes is really annoyingly uninformative. So does this mean that there was just 1 band in the CSF and none in the serum?
Yes, that is it. Our lab report.
So that's the way to do it. I agree.
Number of bands in the CSF. There's only 1 in the CSF and none in the serum.
Perfect. So that's the way I like to see it reported. And then you can't use the word a single oligoclonal. It's a monoclonal.
It's a single, yes.
Oligo is 3 or more.
Yes, it's one.
That's an editor, a former editor-in-chief's point.
Yes.
That's very.
We're picky people.
Give me the blood, give me the CSF. You have both.
Right.
Very
So that's very good.
And then Then additionally, as I mentioned, she underwent whole body imaging to assess for any systemic malignancy, and also for, again, the tuberculosis was on the list to assess for any history of an infection like that, or sarcoidosis as well. But there was no evidence of anything like that, actually. So it was pretty unremarkable, to assess for lymphoma as well. So it was a good screen, including a full body FDG PET, which better sensitivity than just a CT scan for sarcoid. But these were all unremarkable. So at this point, we received lab work back. So she had a Mayo peritoneoplastic panel sent, because that was a concern, as I mentioned previously. In addition to this, an NMO IgG sent, which resulted as positive. This was an ELISA, it was not a cell-based assay at the time, but the titer was pretty convincing at 17 units. The cutoff is about 5. So this was pretty convincing positivity in terms of the anti-aquaporin 4 that was documented. And at this point, when I first saw the result, it wasn't really something I was expecting, to tell you the truth, because I had not associated radiculitis with with neuromyelitis optica spectrum disorders in anti-aquaporin 4 seropositivity. But looking in the literature, I came across a publication in the Green Journal, actually, from 2012. In which they had reported 2 cases of lumbosacral radiculitis with anti-aquaporin 4 seropositivity. I'll go briefly over the cases, because I know that I think we're running a little bit late for time, a little bit over time right now. But in any case, so one was a patient who had a history of longitudinally extensive transverse myelitis with anti-aquaporin 4 seropositivity, who developed a conus lesion with post-contrast enhancement of the conus and the cauda equina. And this patient was actually passed 2 years later from unrelated causes and actually underwent autopsy, which I will show the pathology from that. And then the second case was, so this case a little bit less convincing, but it was a patient who had a presentation that was diagnosed as GBS and was found to have enhancement of the conus and the cauda equina improved with Plex. And they report that subsequent anti-aquaporin 4 testing 10 years later, although it's unclear if this was a serum sample that had been banked from the time or if it was testing 10 years later reported as being positive. And so just showing the imaging and the pathology that they have from this case in their papers. You can see here, so this is case 1 and case 2 in terms of the, can you see my cursor here?
Yes.
Yes. So this is the imaging from the 1 case, and this is imaging from the 2nd case. So we can see a lesion involving the lower spinal cord with post-contrast and enhancement of the ventral cord and the conus medullaris and the cauda equina here. We can see that in the 2nd case as well. And so as I mentioned, the 1 patient passed from natural causes, and there was they were able to obtain spinal tissue for staining. So in H and I are, this is a myelin stain, and this is the aquaporin 4 stain, respectively, from this patient. And so we see demyelination involving both the ventral cord here, as well as actually the inner portion of the nerve root here, which they've magnified in J, with a complete loss of aquaporin 4 reactivity in that region of the ventral cord there. And then what they show here in KL&M are, they report, this is a normal control, and they're trying to show here the aquaporin 4 staining in this region. So in K, they show that aquaporin 4 was expressed at the inner part of this is the anterior root, and L is the posterior root, the cauda equina, and it's suggesting that there is actually aquaporin 4 expression there. And then in M, they're showing protein P0 staining, which is associated with the peripheral nervous system and with a constituent of myelin, the peripheral nervous system, and showing that in the inner roots, it's actually, so this is the transitional zone region between the central myelination with oligodendrocytes and with Schwann cells, showing how that protein P0 is absent in the inner portion of the roots here, and that area corresponds with the area of aquaporin 4 staining. And so what they suggest in this publication is that the area that was affected by the anti-aquaporin 4 mediated process was in the transitional zone between the PNS and CNS myelination at the inner portion of the nerve root, which is shown nicely here in the, I feel, in the pathologic specimen.
That's very nice.
That's a beautiful case. And Elias, I know we have to move on, but I hope you and your mentors colleagues will consider putting that together for us as a submission for our new N2 section, which is the National MS Society Case Conference Proceedings for Neurology N2. So that's a beautiful, beautiful case. I agree with Bob.
Elliot?
And, yes.
It's Scott Zamville.
Yeah, hey,
I'm not coming through on that. I'm on my phone. I just wanted to say that
sound good.
reiterate and underscore the loss of A2P4 is a real critical point there in the pathology for differentiating that as being targeted here. The only thing that you might want that sometimes is shown is if they had shown a C9 neo, something showing complement or IG deposition as well in the papers, in the cases that you're showing in the KNL.
Yeah, very
important teaching point is the A2P4 loss is critical.
Yep. Very
They
good.
may, the way they handled the specimen, Scott, they might not have been able to stain for it. I don't know.
Okay. I
The
think we'll
Neo
go
had,
ahead.
you know, the Mac.
So at 5:21, I think we'll transition to the second case and get William up. And great discussion. And Elias, thank you so much. Fabulous.
Terrific.
All right. Can everybody hear me?
Yep, you're great.
Yes.
All right. So this is a case that came to the neuroimmunology clinic a couple of months ago. It's a 58-year-old Caucasian female presented with about a month of worsening lower extremity weakness, not characterized as severe weakness to the point of falling, but probably more of a balance issue than anything, perhaps a little bit more on the left than the right. Some lower extremity numbness and tingling, again, kind of poorly described. Slurred speech, some trouble swallowing, mostly to solids, not necessarily to liquids, horizontal diplopia, and trouble with her balance, with basically multiple falls. From what we know, this came on over probably a few weeks prior to when we saw her, and we'll go over what happened at that initial hospitalization before she came to our clinic. So, like I said, her symptoms were subtle at first, but prior to presentation had kind of picked up. They were more prominent. She was not exhibiting confusion, abnormal behavior, hallucinations, anything like that, and no infectious symptoms that we know of, no fever, chills, sweats, anything like that. So like I said, some lower extremity numbness and tingling, and an impaired sense of taste for the last 2 to 3 weeks. She was caught up on that. Let's see. So just going through her past medical history, she was a fairly healthy lady. She just had esophageal reflux disease. Her father had myasthenia. She's a smoker, 10 cigarettes a day for most of her life. Her son is a nurse, so they're very health conscious people, very health literate. She's on aspirin and atorvastatin, calcium and vitamin D supplements. Going back through her review of systems, she did note some lower back pain that was fairly non-specific as well. Sounded musculoskeletal in nature. And the thing that kind of pops out is she's reporting a 30-pound weight loss over the last 6 months. It probably was a little bit more recent than 6 months. She reported with this trouble swallowing and low appetite. So it was probably more in the last 1 to 2 months. But like I said, she denied associated B symptoms with that. Let's see. So this is what we had when she was seen initially. So this is from a prior hospitalization at another facility in town, presenting with this just kind of hyper intense T2 signal in the brainstem and cerebellum and pons mostly, with this kind of I guess salt and pepper like enhancement pattern, and I've shown a sagittal just to get an idea of how it looked. So pretty prominent findings there.
William, this is Elliot. Just real quick. No history in this woman of any episodes, preceding episodes of recurrent or cyclic vomiting, or that wasn't part of it?
No, sir. She did not have any of those symptoms.
Okay.
So again, that imaging was from a previous hospital admission in town, where she had been basically seen, and she had a lumbar puncture with basically, I believe, 35 WBCs. We're going to show the labs in a minute. But she had basically a presumed inflammatory syndrome, treated with high-dose Solu-Medrol for 3 to 5, I believe 3 days, and received 1 dose of IVIG. We never reported rapid improvement after steroids, and she was basically discharged with instructions to follow up within 1 month with another local neurologist. So following that, about 4 to 6 weeks later, she presents to us with 4 to 6 weeks of worsening symptoms, kind of as previously described, basically the same syndrome, but more prominent gait dysfunction, falls, and worsening double vision. And she was not discharged on long-term steroids when she left the hospital. She just received that 3 days of high-dose Solu-Medrol. Let's see. And on her exam, she's awake, she's alert, cognitively appropriate, cooperative. Just some mild palatal buccal dysarthria. It's not severe, but it's noticeable slurred speech. Her strength is normal. No objective sensory deficits, though she does complain of these lower extremity paresthesias. She's very broad-based, truncal kind of ataxia on exam. She's not able to stand up unassisted, impaired rapid alternating movements in the upper extremities, and moderate dysmetria seen in both in the upper and lower extremities. She's hyperreflexic, bilateral patella with non-sustained ankle clonus, and her toes were equivocal. And the upper extremity reflexes were I believe 2+, no Hoffman.
William, I assume the general physical was okay. No,
it was.
Didn't
Yes,
look
sir.
cachectic or
No, sir. She looked
chronically ill?
generally no distress, well-appearing female. Yes, sir.
Okay.
No jaundice, no scleral icteric changes. She's got no mets to the liver and then brain and paraneoplastic, but the diagrams look good. And
Right. Yes, sir. Everything from a general perspective looked good.
okay.
So this is the
Hello.
so she came to our hospital. Basically, this is the what I was going over. So this is about a month after initially being seen at another facility. So you can see just the hyperintensity in the PONS is a lot more pronounced, and the enhancement is a lot more pronounced as well. Let's see, I think we have some cord imaging as well next. So you can see that there's some scattered hyperintensities in the cord as well that are enhancing. And this goes down to the, sorry about that, the thoracic spine as well. Similar appearance basically to the cervical
Do you
spine.
think her meninges are lit up a little?
Yes,
I've been asking myself that question. I think
ventrally, cervical ventral.
There's also one at 2, 3, 4, between 3 and 4 posteriorly.
Yep.
I mean, I know younger people can have, you can see meninges because they have decent blood flow and so forth, but that's awfully suspicious.
right.
And contiguous.
Yep.
So these are the labs. So some basic serum labs were normal, and ANA, rheumatoid factor, SSA, SSB, complement, ANCA. Those are all within normal limits. Her SED rate was mildly elevated and her CRP was 20. So some evidence of inflammation going on. This didn't come back right away, but while she was hospitalized, in a Mayo Clinic perineoplastic antibody panel was sent off, and that was negative.
By the way, CRP is
Yes, sir.
inflammatory. SED rate can be other things.
Right.
That's right.
Because abnormal proteins, ratios of proteins,
Old
it
fart
coats the red
syndrome.
cells. It coats the red cells. So myeloma patients like have 120.
Right. Okay. So this is the CSF we got when she was in our hospital. Glucose was 57, protein 34. Her VDRL was non-reactive. She had 18 white cells, 97% lymphocytic, no reds. On the LP, about a month before, the white count was 35. Otherwise, similar labs in the CSF. Not really any difference in the protein or glucose at that time. She had flow that was negative, and cytology was negative as well.